Hello and welcome back to my YouTube channel. In today's video, I will be talking about non-germ cell tumors of testis. So let's get started. The classification of non-germ cell tumors of testis include pure sex cord stromal tumors, in which comes the Leydig cell tumor, Sertoli cell tumor, large cell calcifying Sertoli cell tumor, granulosa cell tumor, adult granulosa cell tumor, and juvenile both, fibroma and thecoma group. And in mixed and other sex cord stromal tumors, there are mixed sex cord stromal tumors, signet ring stromal carcinoma, myoid gonadal stromal tumor, and sex cord stromal tumor not otherwise specified. In this lecture, I will be talking about Sertoli cell tumor, Leydig cell tumor, granulosa cell tumor, both juvenile and adult type, and fibroma thecoma group, as these are important tumors of testis in the sex cord stromal category. Few points to remember. Juvenile granulosa cell tumor is the most common congenital testicular tumor. It is more common in neonates and infants. Sertoli cell tumors are common before age of 1 and they are associated with Peutz-Jeghers syndrome and Carney's complex. And Leydig cell tumors are the most common tumors in 3rd to 5th decade of life. So these are some points which you should remember. They can come in MCQs and you have to answer them. Coming to Sertoli cell tumor. The Sertoli cell tumor is a sex cord stromal tumor of testis which is composed of cells showing features of fetal, prepubertal, adult or atrophic Sertoli cells. It is the second most common type of pure sex cord stromal tumor after Leydig cell tumor. The patient usually presents with slowly enlarging unilateral testicular mass, and testicular pain can be an incidental finding also. Grossly, these tumors are benign, well circumscribed, mostly between 2 to 5 centimeters. The cut surface is usually homogeneous white or yellowish. Cystic component can be present in 30% of cases. The tumors which are malignant are generally more than 5 cm with poor circumscription, extratesticular extension, and presence of necrosis and hemorrhage. Talking about the microscopy of Sertoli cell tumor, generally the architecture is in tubular cords, tubulopapillary patterns. Other patterns are macro or microcystic, nested, trabecular, whorled, solid, retiform, pseudopapillary patterns. Most of the tumors show mixed patterns. The cells of the tumor are usually clear and with abundant cytoplasm which is foamy, eosinophilic or markedly lipidized. There is presence of bland, uniform, round to ovoid nuclei in benign tumors and small hyperchromatic or large nuclei with prominent nucleoli in malignant tumors. There is variable stroma with basement membrane-like material around tubules. The stroma can be sclerotic, myxoid, edematous, or angiomatous. In these tumors, if sclerosis is present in more than 50% of the tumor, it is known as sclerotic variant of Sertoli cell tumor. The positive stains are SF1 and nuclear beta-catenin. Talking about another type of Sertoli cell tumor, which is large cell calcifying Sertoli cell tumor. Well, these tumors are associated with Carney's complex in 20 to 40% of cases, and multifocal and bilateral testicular involvement in more than 50% of the patients with Carney complex is seen. These tumors show characteristic laminated psammomatous mulberry-like calcifications as depicted by the arrow in the image. Leydig cell tumor. It is the most common sex cord stromal tumor of the testis, and it is comprised of cells which resemble non-neoplastic Leydig cells. Only a small minority of these cases, less than 10%, are clinically malignant. The patient can present with gynecomastia or precocious puberty with palpable mass, as these tumors produce testosterone. Grossly, these tumors are well circumscribed with brownish cut surface as shown in the image, and usually they are less than 5 centimeters in size. On microscopy, there is diffuse growth of polygonal cells with abundant eosinophilic cytoplasm, uniform round nuclei, and prominent central nucleoli. The IHC positive stains are inhibin A, calretinin, melan A, SF1, and AR. Features which are associated with malignant potential include size more than 5 cm, infiltrative borders, cytological atypia, frequent mitosis more than 3 per 10 higher power field, vascular invasion, and necrosis. Coming to adult granulosa cell tumor. Well, these are sex cord stromal tumors which resemble granulosa cells of the Graafian follicles of the ovary. Grossly, these tumors are well circumscribed and are predominantly solid. Occasionally, they can have solid and cystic components both. These tumors are lobulated, yellow tan or tan white cut surface is there. Infiltrative borders and extratesticular involvement, hemorrhage, and necrosis are rarely seen, and when are seen, it's associated with a more aggressive behavior. Macroscopically, they show patterns which are diffuse or solid, insular, and spindled, and the neoplastic cells have abundant clear to eosinophilic cytoplasm with round nuclei, nuclear grooves, and presence of call exner bodies, which are microfollicles with eosinophilic material. This is characteristic of adult granulosa cell tumor, the presence of call exner bodies. The tumor cells are admixed with varying amount of fibrocollagenous or edematous stroma, and the positive IHC stains are inhibin A, vimentin, and CD99. Juvenile granulosa cell tumor. Well, these neoplasm are composed of primitive appearing granulosa cells growing in solid and follicular patterns. They affect patients from 30 weeks gestational age to 10 years old, with 90% of them occurring in patients less than 6 months of age. They are associated with undescended testes or dysgenetic gonads. Grossly, these tumors measure 0.5 to 5 centimeter. These are well circumscribed tumors and have a yellow, orange, or tan white cut surface. They can have a solid or cystic component or both solid and cystic component. Microscopically, diffuse nodular and follicular patterns are seen, and the cells have moderate to large amount of pale to eosinophilic cytoplasm, round to oval hyperchromatic nuclei, some of which contain nucleoli. Mitosis are common in contrast to adult granulosa cell tumor, and extensive hyalinization and prominent myxoid background may be seen. The IHC stains which are positive are FOXL2, SF1, and vimentin. Coming to the fibroma thecoma group, these tumors are sex cord stromal tumors composed of spindle, oval, or round cells with varying amounts of collagen. Grossly, these tumors are well defined firm tumors with a cut surface which is tan, yellow, or white and can be solid to cystic. Microscopically, these tumors are circumscribed but unencapsulated and are arranged in fascicles, storiform, or a combination pattern in collagenized stroma with small blood vessels. Herringbone pattern can also be seen, and usually there are scant mitosis, less than 5 mitosis per 10 high power fields. If more than one microscopic focus of other sex cord stromal tumor cells are seen, then it is classified as mixed or unclassified, since these tumors have metastatic potential unlike the classical fibroma. Treatment of these tumors is generally high inguinal orchiectomy. Testicular sparing surgery may be attempted in smaller tumors. Retroperitoneal lymph node dissection can be done if clinical or radiological evidence of metastatic disease is seen. I have completed testicular tumors in 2 lectures on my YouTube channel. I hope these lectures will benefit you all. See you in the next video. Bye for now.